genetic counseling for pancreatic cancer patients and families, review and updates during COVID-19. My name is Amy Reese, and I am the Patient and Family Support Coordinator for the Hirschberg Foundation. Aggie Hirschberg, our founder, is here too and looks forward to saying hello at the end of the webinar. Please ask your questions either during or after the slide presentation by clicking on the chat button at the bottom of the screen and type and submit your question. We will open the discussion for all after the presentation. The webinar is being recorded, as Alyssa mentioned, and will be made available on our website, pancreatic.org. Now, I'd like to introduce today's presenter, Wendy Conlon, a genetic counselor with UCLA and board certified by the American Board of Genetic Counseling and licensed in California. Wendy oversees surveillance of patients and their family members, provides risk assessment, genetic counseling, and genetic testing to those affected with pancreatic cancer and their at-risk relatives. She helps individuals and families navigate their treatment options as well as other cancer prevention strategies. Thank you so much, Wendy, for joining us today to share this valuable information.
Thanks for having me today. I hope everybody's doing well. I know that these are stressful and uncertain times for all of us, and we've had to navigate a lot of changes. So I appreciate you taking time out of your day to have this conversation with me. I think that I like to look for, is there any advantage to the coronavirus pandemic? And I think that we have had kind of some amazing things that have happened. Now my slide's not forwarding. Hang on one second. I think the best thing that's come out of the pandemic for me professionally is that we were able to rapidly transition to telehealth video visits for our patients. And while we had been offering them before, they really weren't very popular with people. So we had a handful of folks that, periodically would say, hey, can we have a video visit? And we could accommodate that. But most of the time people were coming in to see other healthcare providers at UCLA, or they still wanted an in-person visit. And, we weren't able, people just weren't taking us up on our offer to have the video visits, but we were ready. And so when this whole thing happened and we wanted to keep everybody safe, we switched over to video visits, as a lot of providers have. And so many people at UCLA, many providers are offering these video visits so that you don't have to come in and see us, whether it's your MD, your nurse practitioner, or other healthcare provider that doesn't necessarily need to put their hands on you or do anything physical when you come in to see them. We can do this using a smartphone with a camera, so your iPhone or Android device works really well. The way that we're doing these visits is through the UCLA Patient Health Portal, the MyChart portal, which is the same thing that you use to check your appointments with your UCLA doctors or doctors at other institutions that use the Epic electronic medical health system. And it's pretty easy. You just click on the app on your phone, you pull up your information by putting in your password and your username, and you can see all of your visits there, and just click on the video visit, and then we're face-to-face with each other. Telehealth helps keep everybody safe. Like the whole point of the stay-at-home recommendations is to reduce people's interactions with each other. So if we can keep you at home, you stay safe, you can be in the comfort of your own home, and you also protect healthcare providers and reduce the use of personal protective equipment like face masks in the clinical setting. And so, I made a joke earlier that, you can see your healthcare provider from the comfort of your own home wearing comfy pants or even maybe no pants. That's kind of the joke of, having all these Zoom meetings and video visits is you can wear what you like and be on your couch and not have to travel in to see us or pay parking costs or take a day or a half a day off from work. It's pretty seamless, and you don't have to wear a mask. We think that 90% of our communication between people is through verbal cues. Your facial expression helps me and helps anybody talking with each other to get a better understanding of your emotional state and get an understanding between two people, because words sometimes can be miscommunicated, but me talking to you and seeing your face helps me understand what you're feeling and thinking in a better way than if we were both wearing masks in the clinic. And genetic counseling is perfect for video visits because we don't need to lay our hands on you or do anything physical with you while we're talking about your personal and family history and what genetic testing is available. There are some limitations. Some people don't have access to Wi-Fi in their home, or they have unreliable Wi-Fi, or maybe they don't have a smartphone with a camera. And then some folks have discomfort with technology or lack of experience with technology. Here at UCLA, we've got folks that are in IT that can help you with setting up the video visit if you have some discomfort, and I can even do it. So, like one of my jokes is like, maybe I could have a second career as an IT support person, having gone through this experience, because we're here to help you set up the video visit and make sure that you have comfort with it so that you're not floundering. But then if it doesn't work, we can always switch to a phone visit to complete the visit, and that works very well as well. So we've got backup plans, and we want to make this as comfortable as possible so that everybody's needs are met and that you're not struggling. Commercial insurance pays for video visits. I think all of our insurance providers have stepped up in this pandemic to make sure that people have access to healthcare providers. So all the commercial insurers are paying for video visits using the standard genetic counseling CPT code, or the physician billing CPT codes, which are the codes that they use for reimbursement back to your healthcare provider. The other great change that's occurred, and hopefully it's permanent, but when the pandemic hit, Medicare changed their regulations. So prior to this, if you were a Medicare recipient, you could not have a telehealth visit with a healthcare provider that you hadn't already seen in person. So they switched that rule, and they said, okay, if you've got Medicare, you can see a new provider, whether it's a new MD or a new nurse practitioner, by video if you need to, and they were reimbursing for that visit. Genetic counselors aren't recognized as healthcare providers by Medicare, so regardless, we kind of didn't fall under this new golden rule. The way that we do our visits for Medicare recipients so that they don't get a large bill is we have our physician supervisor, who's a medical oncologist, join the visit, and we conduct the visit together so that we can bill using the physician CPT codes so that the patient doesn't get a large bill for the genetic counseling appointment, because physicians can provide genetic counseling, and we work together to gather your family history, talk about the genes that are available, and order your testing. And so really the game changer, bottom line is that, because of COVID-19, patients have access to video visits with their healthcare providers regardless of their health insurance, which is a really great new thing that's happened. So one silver lining. The other way that we continue with kind of a contactless, safe specimen collection is we get your DNA by shipping you a saliva kit. And then people always ask me, well, is saliva as accurate as blood? Accuracy for testing depends on the lab that's doing the test, not the specimen type. So saliva or blood or something maybe more invasive like a, liver biopsy or skin biopsy, all of those mechanisms are collecting cells from your body, and it's the cells that we're collecting that we extract the DNA from to run your genetic testing. The genetic testing is just as accurate because we're starting with the same starting material, DNA, and sending it to a lab that's a medical grade certified laboratory to do the genetic testing. So it works pretty well, and you don't have to come into clinic to have your blood drawn. You can collect your saliva from the comfort of your own home. There are some medical conditions like an autoimmune condition called Sjogren's, where it might be difficult to provide saliva because you have dry mouth. And then there are some folks that we can't collect saliva from because of other underlying health conditions like low white cell count. And in those cases, we would either need you to come into clinic to have your blood drawn, or we can send a phlebotomist, a person out to your house to collect a blood sample if needed. But that's a rare circumstance. And so I'd like to segue into what I do in genetic counseling. So, all cancer has a genetic basis in that the tumor itself has acquired some genetic changes, and those genetic changes are allowing those cells to grow out of control. For most people, they are randomly acquired either due to aging, lifestyle, environmental risk factors, or just very bad luck, or some combination of those things. There are people who have inherited mutations in really important genes that control how your cells grow and divide or repair DNA. And those folks are at increased risk to develop cancer, but they still have to acquire other genetic changes in that cell that ultimately becomes the cancer. It's just that their risk is higher to acquire those other changes because of the inherited mutation in that one gene. And we'd like to figure out who those folks are because we would do things differently for them. That's the promise of precision medicine, is to identify people who have higher risk so that we can start screening earlier or do things differently to reduce their chance of getting the cancer associated with that gene. And so, people who should think about having genetic counseling and testing are anybody diagnosed with pancreatic adenocarcinoma, and people who have relatives who have been diagnosed with pancreatic cancer. Meeting with somebody like myself doesn't obligate you to have genetic testing. I know that lots of people have concerns about what the information would tell you and what the ramifications would be, but meeting with somebody like a genetic counselor allows you to explore those concerns, have a discussion about it so that you're fully armed with all the information and can make the right choice for yourself at that time. The other game changer that happened recently is the National Comprehensive Cancer Network, which is a consortium of physicians. They sit down a couple times a year and they review the treatment of cancer and the recommendations for best practices in that area, which is what they're best known for, but they also review the genetic basis and the assessment of risk in folks who might be at higher risk for cancer. And so for decades prior, this document used to be called Genetic Familial High Risk Assessment, Breast and Ovarian, period. But finally, and gratefully, in December of last year, they changed this document, and I added this really messy highlighter line underneath it, and they added pancreatic. And they recommended now that everybody with pancreatic adenocarcinoma should consider or should have genetic testing, because we know that a not insubstantial portion of people with pancreatic cancer have an inherited mutation in a cancer predisposition gene. And so this just made the recommendations official. And so when that happens, insurance companies tend to fall in line. Maybe not immediately, but I think by this point in time, I haven't had a denial for anybody diagnosed with pancreatic cancer this year who we've ordered testing on. So this helps everybody get access to the testing and get their insurance to pay for it. And so like I was saying, anybody diagnosed with pancreatic cancer at any age, they don't have any age criteria or cutoffs. And they also recommend that anybody who's unaffected but has a first-degree relative diagnosed with pancreatic cancer, and I would argue anybody with a second-degree relative, so that's, a grandparent or aunt or uncle diagnosed with pancreatic cancer, should think about genetic testing, because we usually can get it covered by insurance. And, why would we do this? For somebody who has pancreatic cancer, it could change your chemotherapy treatment. So people with inherited mutations in BRCA1 and 2 are eligible for treatment with PARP inhibitors, and that's an active area of research, and there's lots of different PARP inhibitors that are on the market, some of which have been FDA approved. And then people with Lynch syndrome, or people with tumors that look like Lynch syndrome, due to acquired changes, they respond very well to the immunotherapies, so PD-1 and PD-L1 inhibitors. So it could be important for your care going forward to have this information, in addition to your relatives having this information. We provide a risk assessment, so we take into account your personal and family history. There are lots of genes that we test people for. Typically the minimum number of genes that I test people for in my practice is about 40-ish genes. We like to test at least for all of the genes that have medical management guidelines. And the reason for that is, maybe you don't know your family history really well, or your relatives were private about sharing their medical history. We don't want to miss somebody who might have a gene that's actionable that we could do something to improve health outcomes for. And so, we're here to guide you through the process, order your testing, and make sure that the management plan is in place so that you can use this information and leverage it for health. Just in brief, we're not just talking about pancreatic cancer. So it's not that there's one gene that increases the risk for pancreatic cancer. These are genes that are really important for controlling how your cells grow and divide and repairing DNA damage. And so in families that have an inherited mutation in the cancer predisposition gene, we usually see folks who've been diagnosed with cancer at a young age, whether it's, premenopausal breast cancer, less common cancers like pancreatic adenocarcinoma or ovarian cancer, or people of certain ancestries. So people of Ashkenazi Jewish ancestry are more likely to carry mutations in BRCA1 and 2. People who are Icelandic are more likely to carry mutations in BRCA2. So we take into account those factors as well. And we use that to figure out what tests to order and how to manage you. Family history is still really important. Inherited mutations in cancer predisposition genes are not as common as cancer in general. So, most people who develop cancer will not have an inherited mutation in a cancer predisposition gene. But, if we look at all people with pancreatic adenocarcinoma as a whole, recent studies over the last 5 years have kind of given us a range of, if we just take somebody who's diagnosed with pancreatic adenocarcinoma and we don't know anything else about them, we estimate that there's an at least maybe 5% chance to have a gene mutation that caused the cancer, up to maybe a 14% chance. So that's a pretty wide range because, studies have been done in different parts of the country, and there's some variability between the test populations. But in any event, even if we assumed that the gene mutation frequency was, only 4%, it still would be reasonable to have the testing because of the impact a positive test result would have on you potentially, if you had pancreatic cancer and a gene mutation, for changing your chemotherapy or adding something to your chemotherapy that would improve outcome, and for your relatives who might be at increased risk for not only pancreatic cancer, but cancers that we can prevent, like ovarian cancer, or cancers that we can screen for and catch earlier, like breast cancer, which has a much better outcome if it's detected earlier. So there's a lot of advantages. People who have a family history of pancreatic cancer are at increased risk. And so one of the things that genetic counseling does is it helps centralize your information about your family history and put a plan in place, even if you decide not to have genetic testing, or even if you have genetic testing and it's negative. If we know that you have 2 close relatives with pancreatic cancer, like two first degree relatives, like a mother and a sibling, or even if you have 2 close relatives, like a parent and a grandparent, your risk is elevated compared to somebody who doesn't have a family history of pancreatic cancer, and you're eligible for high-risk surveillance, so screening of your pancreas, even in the absence of a gene mutation. And so it's helpful to get that family history together in one place and a note that recommends that. And then people who have, this is kind of repetitive, but people who have mutations in cancer predisposition genes, like I described, they usually have family histories of people with the other cancers that we see in those syndromes. So for example, people with a mutation in BRCA2, within those families, we tend to see women diagnosed with breast cancer premenopausally, individuals with ovarian cancer, individuals with prostate cancer, in addition to pancreatic cancer. So that's what we're doing when we're collecting the family history. And then this is a small subset of genes that we know increase the risk to develop pancreatic cancer and other cancers, and there's a range of risks. So Pancreatic cancer, being diagnosed with pancreatic cancer is a scary time for patients and their families. And sometimes just thinking about having genetic testing worries people and their relatives because they think it means they're going to be guaranteed to develop pancreatic cancer. And so while the risk is elevated if you have an inherited mutation in the cancer predisposition gene, it's not a guarantee that you would develop cancer of any kind over the course of your lifetime, even if you live to age 90. It's just that your risk is higher compared to somebody who doesn't have an inherited mutation. And we would like to know that so we could leverage that information. Start your screening earlier, do different screenings. And the goal of that is always to either catch a cancer early when it's much easier to be treated, or prevent a cancer, not to make people worried that they're definitely going to develop cancer over the course of their lifetime. It's just that this is the promise of precision medicine because, we all have different risks for things, right? So we're not all born into this world with the same risk for diabetes or heart disease or cancer. And it makes more sense to me to do something to risk stratify people into different groups depending on their actual risk rather than a one-size-fits-all for health screening. So that's why, but that's my bias as a genetic counselor. And this is another list of cancer predisposition syndromes and kind of like the typical things that we like to screen people for and the types of cancers that we can see in family members. BRCA1 and BRCA2 account for most of the mutations that we will see if we see a mutation in somebody with pancreatic cancer. And a lot of the other cancers that we see in folks who carry these mutations, we have data to show that the screening works. And I feel it's important to identify these folks in the population because we can start screening earlier. The risk for the other cancers that are associated with these mutations are much higher than what we see for pancreatic cancer. And we have something that we can do for the pancreatic cancer risk. People who should have screening for pancreatic cancer, as I've already described, are gene mutation carriers, people with strong family histories, and the age to start the screening depends on the gene involved and your family history. So this is where putting it all together helps us make a plan for you and your relatives. And the screening that we do is an MRI-based screen of your pancreas called an MRCP and an endoscopic ultrasound. So that's using endoscopy to get in down through your esophagus into your stomach to ultrasound your pancreas, getting as close to it as possible to take a look at it. And it's those two images together that allow us to screen your pancreas. I recommend that the specialized screening, if you elect it, if you're unaffected, you have a family history of pancreatic cancer, or if you're a gene mutation carrier and you have a higher risk, is to go with folks who do this all the time, and that's their area of expertise. The difference between screening for pancreatic cancer and screening for breast cancer is the following. Millions and millions of women have mammograms every year, right, for breast cancer screening, even if you have no family history of breast cancer, because it's a common cancer. And we know that that screening works. So we know that mammograms work to detect early stage breast cancer and improve outcomes. Same thing with colonoscopies. Everybody should be getting a colonoscopy. Used to say 45, now used to say 50, now we say 45. And we have data to show that that works to even prevent people from getting cancer because we remove these precancerous polyps. We have lots and lots of good data to support those two screening methods for those common cancers. In the realm of pancreatic cancer, pancreatic cancer is less rare, is less common, more rare, and not as many people get screening. So that's why we say, go with this experienced center. And we're collecting data. We have some emerging data that supports the MRCP and EUS, detects pancreatic cancer earlier where surgery is possible. And we know that that's going to improve outcome, and we're still getting enough data to prove that. To prove that it leads to improved survival and longer lifespan. So, getting screening, getting this data is super important to show that it works, so that we can get more people interested in screening, so that we can improve health outcomes. That's our ultimate goal. And like I was saying, these are really kind of crazy times. This pandemic is putting a lot of stress on, all of us. And one of the things that I talk to my patients about is now the right time for genetic testing. because it's still individualized, right? So this is a strange and scary time. There's lots of uncertainty for folks, whether it's medical or financial, like maybe you had a job loss, maybe you're worried about losing your health insurance. There's lots of social stressors, just to make light of it, maybe you're spending more time with your significant other in a small environment, and that's leading to stress, even though you love them very much. So there's lots of changes that we have to adapt to that are creating stressors for us, and then a lot of uncertainty because we don't know when this is going to lift. When we're going to have more effective treatments for COVID-19 or maybe a vaccine. So there's just kind of a lot of stressors right now. For people who are unaffected, who are worried about a family history, now might not be the right time. People really need to have a discussion with themselves and a genetic counselor to talk about when they want to have screening or if they want to have screening. I would say that a lot of things have gotten better. So, at the beginning of the pandemic, I would have to warn people that, if you were to test positive, you might not be able to get that screening colonoscopy or that EUS right away because, we were reducing certain procedures that weren't emergencies, essentially. So if you had no signs or symptoms of anything serious going on and it was just a screening test like a colonoscopy, we weren't doing them. Now at UCLA, there are no screening related or scheduling related delays for things like EUSs or MRCPs or colonoscopies or mammograms. So we're back to doing those procedures normally, scheduling those procedures normally with, with precautions, obviously related to COVID-19 in terms of physical distancing, sterilization, safety practices and things like that, but you're able to get those appointments and have those procedures done without any delay. So, just in summary, healthcare needs are still important. If you have any concerns about your health, whether it's unrelated to cancer, like, you need to go see the dentist or get your vision checked or have a well woman visit, you still need to do those things, and your healthcare providers are here. And I think that our healthcare system has been really adaptive in meeting those needs. And I think that we're looking forward to having people come back into clinic face-to-face when needed. And if you don't need to see somebody face-to-face, like talk with your doctor about an ongoing concern or meet with a genetic counselor like myself, you can do it by video, and that keeps us all safe and is actually, better for the environment and maybe better for you in terms of your day-to-day scheduling. So, we're all just trying to do our best and deal with the stressors that we have. And I hope that you'll reach out to your healthcare providers as needed, and that we all stay safe and sane. This is a list of all the genetics providers at UCLA, and they all are listed here with their contact information. And, most folks are providing video visits here at UCLA and elsewhere. If you don't live in California, there are lots of genetic counselors around the United States. And so I put a listing here that helps you find a local genetic counselor if you live in another state. And this is just a summary slide, so genetics can give you a personalized risk assessment, even if you decide you don't want to have the genetic testing, and that information can be used to assist in your medical management and treatment. It can be important for your family members. There are also downsides, there's some uncertainty still with genetic testing. Sometimes we can get an inconclusive or ambiguous result. Sometimes it can cause more stress and anxiety for people, or problems or conflicts with your relatives, or feelings of guilt that you might have if you have an inherited mutation, or sometimes you're feeling guilty because you don't have an inherited mutation that a relative has. So we're here to help you navigate all of those potential pitfalls and get you to a place where you're doing the things that you feel comfortable with and you're leveraging them to improve health. And I just want to thank the people that I work with closely at UCLA, Dr. Seal and Dr. Gans. They help us with our Medicare patients and then directing and supervising us. And then I've got another colleague, Rachel Shapira, who's a fabulous genetic counselor who also sees patients just like I do. So I'm hoping that I can help answer any questions next. So thank you so much for inviting me.
Wendy, thank you. That was terrific. Great information, as always. We're taking questions from our group chat. If anyone wants to write down a question or can just unmute themselves and ask a question as we're going along here.
Hi.
Hi.
Hi. That was excellent and loaded with great information. Thank you. I have a question.
Yeah.
I don't mean to put you on the spot. Just so you really quickly get the background, my grandparents on my mother's side my grandfather there's 3 brothers, my grandfather and his 2 brothers.
Okay.
Each of them had a child that died from pancreatic cancer. One of those children was my mother.
Okay.
So it's a really peculiar familial pattern, which they were unsure about even agreeing was a pattern, but it's too much pancreatic cancer to not see it. And I think I found a couple more cases going back through the death records, way back when they just called it liver cancer because they didn't dig more.
Mm-hmm.
I'm with Kaiser, and with Kaiser in not West LA, up at Sunset, and they have pancreatic cancer kind of not specialty, but a guy, Dr. Wu, who's great, who's good. And I gone in years ago and said, I need you to start screening me the way they're screening in the studies. I need you to jump ahead to what they're going to find and just start screening me. My mother died. I'm a young mom. And he did.
Okay.
And I'm wondering now, what else? I just went for my MRI about a week ago, which was really eerie going to the hospital during this time.
Yeah.
But I'm not skipping that scan. Not going to skip it. What else should I be doing besides, and are the people who are at Kaiser, like, this is the part that I don't mean to put you on the spot, but are they up to this task? Because I think of them as not up to this task.
Well, they have healthcare providers who are trained in doing EUS and MRCP who are experts at providing that kind of screening. So I don't think that their doctors are, like, you live in Los Angeles. So, this is kind of, my bias is, we here are very privileged to live in this large urban area and have many, many centers, Kaiser, Cedars, UCLA, USC, City of Hope, who do many of these procedures. We're not talking about community hospitals where, maybe once a month or once every 2 months they're doing an EUS. So I don't think that you're in bad hands at Kaiser for your screening procedures.
And would you also add an EUS on the endoscopic ultrasound? So far, I've just done the MRIs.
I think it's a good idea because they're 2 different imaging modalities. So they give you similar but extra data so that they both can be compared to each other to monitor for any changes. Okay. And then you've heard that saying, if you're a hammer, every problem looks like a nail.
Right.
So I'll put myself under that thing, like I'm in genetics and, you've got a family history of pancreatic cancer. And I don't know if you've had updated testing or any genetic testing. I do think that that's a good idea given your family history.
I have not had updated testing. When I was pregnant, I found a lump in my breast. And because I couldn't go back for the follow-up mammogram, we did genetic testing. I demanded they test for BRCA1 and 2 because I thought that would be the sign, my mom having just died from pancreatic cancer. And then that gene, I thought that would be the magic combo of to do something. But we were able to figure it out and to wait. So that was the extent. I did genetic counseling, but it's come so far in the last 10 years.
Things have changed a lot. So right around 2015, things just changed dramatically, and we are able to order many genes So, like I put up lists and lists of things, typically like the bare minimum is like a 40 gene panel, depending on your personal and family history and risk tolerance. And so you most likely didn't have any of those genes, and it might be a good idea just to go back to Kaiser Genetics and get an updated panel. They have lots of genetic counselors there. I know lots of them personally. They're excellent, and you would get.
Would you recommend one?
Like they're great. Like there's Victor Moser, who's a genetic counselor there, Jody Kirsch. They're all doing video visits.
I love the idea of genetic testing. It doesn't worry me what I might find. I think it's exciting that you can take a peek inside our bodies and help us make better choices along the way and possibly catch something before it manifests. I think it's awesome.
Right. So that's my bias, but everybody's got different risk tolerances and different tolerances for how much screening they want to go through. And then some folks, everybody's got different life philosophies. Some people want to take things as they come or have less screening. You're not obligated to have genetic testing if you meet with the genetic counselor. You're also not obligated to follow my guidance or your physician's guidance. It's still your body, and you have to make a decision about how much screening you want and how frequently you want to do it. So, this is all a negotiation. We're just trying to get as much information as possible about people so that we can have a better idea of what their risks are so we can make plans. But, it doesn't obligate you to anything.
If I may just, and then I'll stop. I'm sure everyone else has questions for you. I wrote down what you said, that you order a minimum, usually of 40 tests for medically actionable genetic testing. If I say something like that, I'm going to pull the study. My Dr. Wu really works with me on this. If I say something like that to the geneticist, they'll know about this endorsement changes. Like, I don't need to tell them, I used to have to outline what they needed to do. You're saying they'll know this now?
Yeah, so, in LA, there's big families, let's say. There's a big family, and some members are Kaiser members, and some members are UCLA members, and some members are City of Hope members. So if there's a family with a gene mutation, they pop up all over the place. And so they'll bring records maybe from Kaiser. So, I know that Kaiser orders genetic testing from high quality laboratories, and that their genetic counselors' practices are very similar to ours, and they're going to do the right thing for you.
Thank you. Thank you. Really.
Rebecca.
Is that Aggie Hirschberg?
Yes, it is. So
Hi.
So we have many patients that come to the foundation from other institutions, and UCLA doctors are very very generous with sharing, and often the patient actually comes to UCLA as well. So I hope that helped.
I know you probably don't remember me, but I spoke with you the morning of my mother's Whipple, and you gave me very great advice. You said if they can't get that out, you tell them just to sew her back up and start that chemo, and then we'll get back in there and try again with the surgery. And that is what I told them to do. I said, do not mess around. You do what you need to do. And if you can't, then we're going to go back another time. And I just talked to Aggie Hirschberg, and that's what she said. So you really helped me toughen up and be there for my mom. And I am grateful to you. I am too.
Thank you.
Oh.
Deborah, it's nice to see you. Tom, I see your name. Can Deborah hear? Can you give a hi? Are there any further questions? Hi, Tom.
I have a question for Wendy. Wendy, if someone's been diagnosed with pancreatic cancer, we know based on NCCN guidelines to go get genetic testing. At what age should they direct their kids to get genetic testing?
Well, it really depends on their result. So if we do the genetic testing, we don't find anything, then we default back to family history. Do they still have a family history that's concerning for screening? Having one relative with pancreatic cancer doesn't rise to the level of recommendations for screening in unaffected children. But if you have more than one relative with pancreatic cancer, that's where insurance companies will usually pay for screenings like MRCP and EUS. And then if somebody tests negative, genetic testing is still continuing to evolve and change, and we'll have more genes. And I'm hoping someday we'll have a better handle on multifactorial genetic risk factors. So one of the things that we don't really understand right now is how genes interact with other genes. Most people's health conditions aren't going to be due to one single gene that is directing risk for cancer or heart disease or diabetes, or name a health condition, right? It's going to be some complex interaction of probably normal gene variants and how they work and interact with each other and our environment and our lifestyle. And that's kind of the missing piece right now for risk assessment and stratification. So hopefully over time, we're going to get more information and have better tests, and people, I tell them to check back in with me in like 2 to 5 years. See what we have that's new.
Great. Any other questions?
Well, I have a question. Hi, Amy. Hi. I'm sorry, I missed you earlier. I know that I'm a pancreatic cancer survivor, 6.5 years, and early intermediate stage, and I've had genetic testing, and I have an ATM mutation, and in my family, my daughter tested positive. There were 6 people in my family that were tested. And of those 6, 3 of us are positive for both pancreatic, colon, and breast for the ATM. Myself, I've been, being tested and followed up for all of those 3, and which is really a plus. I can't help but say how I'm pleased that I had the testing. And would encourage that for others, especially when I went for my 5-year, checkup. My GI doctor's like, "Oh, okay, we're fine. We'll see you whenever." And I'm like, "Whoa, did he forget that I have the ATM mutation?" To the nurse, and the nurse, came back and said, "Oh, okay. Well, we'll see you next year then." And when we did that follow up, we found a precancerous colon, polyp, which was removed. And they've been following through. But I had trouble last year when I went in, which I'm due for any time, and I haven't scheduled those things only because of the COVID virus. I've been kind of afraid to get out and about, and I've been isolated pretty much for almost 3 months before it even came to America, because I have family in Europe, and they were sharing like, you guys need to be prepared, and so we were bunkering in 2 months or 2 weeks before anything even was heard over here. But my question is, it's like I had trouble last year getting an MRI for my breast. Should that be an issue, or do I need to get, pre-qualified for that, or, other than just the mammogram, I don't feel confident in for my ATM mutation and my strong history of breast cancer, along with pancreatic cancer, losing my mother and having several immediate family members with breast cancer. Should they not just automatically do that, or do I just rely on a mammogram?
We do recommend breast MRIs with contrast for ATM mutation carriers. So that's part of the NCCN guidance.
Right. So then that should be something that I could get pre-approved then before I go in then to have it approved, correct?
Yep. Correct.
Okay. So I've been following through, for the last couple of years, and for my breast, I've been doing that since I was in my early 30s, And my daughter, she hasn't done that. She's been following breast, but she hasn't really done for pancreatic yet, or colon, and she's only 32, almost 33 now. Should she start doing for pancreatic and colon as well?
Well, so this is where, your family history and your gene mutation help guide us. So,
right. Well, we're the worst, we're there.
Well, I don't like to use the word worse. That's not true.
Well, I don't think we're the worst. I don't have the BRCA. I'm pleased, but I don't know. I don't want any of them, but
I don't, everybody's got gene mutations. There's none of us here on this talk have a perfect genome.
okay.
we all have inherited mutations in genes or mutations that we've acquired over the course of our lifetime. And I just want to identify them so that we can leverage that information. Because we're all going to get something if we live long enough, and I would like to be smart about it, or try to use the information that we can to help things. So, in terms of colon cancer screening for ATM carriers, we would say start screening at age 40.
Okay.
Unless you've got relatives who've been diagnosed with colon cancer earlier, because we take into account family history. Like, does your family have somebody who was diagnosed at an earlier age, where we would want to start colonoscopies earlier because of that history?
Okay.
And so, breast cancer screening is the same way for ATM carriers. We say start at age 40, and then, alternate. So get the mammogram at 40, and then 6 months later do the breast MRI with contrast, and that's the screening going forward.
Okay. So you're saying my daughter, even though she's 33 and we have an extremely strong history of breast cancer, for her just to wait till she's 40, or?
Well, how young was the youngest person? Like how early?
My mother died, she was diagnosed at 54. I have a niece at 42 that had a triple negative.
Okay, so we would want to start earlier in your family. So
Yeah.
your
Right.
daughter could get her breast, 10 years earlier
Okay.
than the earliest ages at diagnosis is kind of our rule of thumb. And so if your niece was diagnosed at 42, then relatives could start their screening at 32.
Okay. Okay. Thanks. I'm
and
concerned with her. How about pancreatic, though? I mean, for her.
Pancreatic, who's the youngest person diagnosed with pancreatic cancer in the family?
I have 50.
Okay. So, maybe think about age 40
for her to
40
start.
or 45 to start
Okay. Okay.
And our understanding of the cancers associated with particular genes are changing over time as we test more people. So, genes used to be patented and owned by corporations in the US. And in 2013, there was a Supreme Court case that overturned that, so that that patenting couldn't occur. And so prior to, maybe 2015, we weren't testing people for lots of things, and we were kind of, I don't know if tunnel vision was the right thing, but we had an idea of what families and individuals who carried gene mutations looked like. And so now we're testing more people for more things, and we're learning more. And so, as time goes on, our understanding of the risks associated with particular genes modifies over time. Our understanding of what we should do to best manage that risk changes and is refined over time. And then we learned that maybe there are other cancer risks. So the controversy right now is, does an ATM mutation increase your risk for female ovarian cancer? People are, arguing about that right now. So NCCN says maybe there's a risk, which really isn't super helpful. It doesn't guide any changes to care. But if I have an ATM mutation carrier who has a family member with ovarian cancer, I talk to them about preventative surgery to remove their ovaries and fallopian tubes. We don't have a good handle on when that should be done, and there's a downside to doing that premenopausally, but it's a conversation that I think people should have, because we don't have good screening for ovarian cancer. We know that the screening that we have doesn't work.
Okay, that's scary. Yeah.
Wendy, there's Karen asked a question. My genetic testing didn't show any mutations. Should I have my children test?
What year was she tested in?
Karen, can you're not, you need to unmute.
Now I'm unmuted. I was tested in 2018.
Okay, so you probably had a panel done with lots of genes. Do you remember the number of genes you were tested for?
No, I know that there was I'm not sure how you say it, the BRCA 1 and 2 didn't show a mutation at all.
Okay.
And then I believe there were only 4 or 5 that they tested.
Okay. So, you might want to come back and see somebody in genetics and have updated testing to make sure that you were tested for all of the known genes that we know are associated with pancreatic cancer risk, and consider genetic testing for what I call limited evidence genes. So, BRCA1 and 2 don't work by themselves in a vacuum. They work in this complex pathway with lots of other genes that make protein products that bind to each other to carry out a task called homologous recombination, which is the fancy term for repairing DNA breaks. And so some of those other members, we have emerging data that they also increase the risk for pancreatic cancer. And so you probably weren't tested for those because those have become available in the last few years. And while we don't have a good handle on what the lifetime risk is for cancer, if you have a mutation in one of these other genes that are kind of newer that weren't even on the list that I provided, it may be beneficial to get that information because it would help us figure out if there is a risk to your children. If we do all of this, updated testing, let's pretend you had a 100 gene panel and we didn't find anything, and if you're the only person in your family with pancreatic cancer, we would say, well, probably your pancreatic cancer was sporadic. It's, not due to one single thing that we can put our finger on. We wouldn't recommend increased surveillance to your kids. And since you didn't have a gene mutation, we wouldn't recommend that they have genetic testing unless they're worried about something from their dad's side of the family, because you didn't have anything that we could identify. And so by testing them, we're not going to find anything.
I had ovarian cancer when I was very young. And I mean, I'm pretty healthy and stuff, so I'm not too worried. But I know for me, when I'm not a patient at UCLA, I live up on the Central Coast, and I just wasn't sure because the foundation is strictly about pancreatic. I didn't meet anybody up here that I could talk with. Everybody had breast cancer or prostate cancer. I didn't really have that. So these seminars are just so valuable to me. But I wasn't sure if all doctors, when they send in for the genetic testing, do they send for the same panel that you're talking about, or is it that they have to request? I'm wondering, did they just send in for the BRCA and that's my.
I don't know. So I see different things. So rarely, even today, and that it makes me upset, quite honestly. Like, I'll see somebody who has pancreatic cancer, or breast cancer, or some other cancer, and their provider ordered just BRCA1 and 2, or just the Lynch syndrome genes, and that just boggles my mind at this day and age. So I can't ever guarantee what anybody else ordered.
And can you just contact one of the associations that you had listed? Can we just contact one of those people to?
Sure. Or if you want, you can shoot me an email and we can follow up next week, and I can try to find somebody in your area.
Okay.
Or, video visits, if you wanted to meet with me or one of my colleagues here, you can just have a video visit and we can review your prior testing and update your testing. So,
great.
and it's not just UCLA, so it's not just us, there are lots of genetic counselors all over California and the US who are very good at their jobs, whether they're at Kaiser or another healthcare system, and they know what to order.
Yeah.
I'm more than happy to help you with that.
Oh, great. Okay. I'll look forward to talking to you then. Thanks.
Sure.
Okay. I think we can wrap. And Wendy, you are just brilliant, and this telehealth counseling is fantastic. And I look at it as perhaps somebody that's contacting us from North Carolina can have some kind of a visit with you if it's pre-approved financially. So I learned a lot, and I thank you. It was nice to see you, Rebecca. And how many years ago was that, Rebecca?
That was in 2005, in May of 2005. Those dates you never forget. It was a long time ago. and I've followed the work you've done, which has just been amazing. I refer everyone to you. Every time I write about my mom on Facebook, I tell people to put their money where their mouth is and donate.
Raise
So-
money for us, Rebecca.
I do.
So
My
we
group.
can-
You're my
so we
group.
can keep going. Thank you, everybody. And
Thank
stay
you.
tuned. There's another session coming, and if anybody has any ideas of what they would like to hear, we'd like to also hear that.
And one last thing, Wendy, may I provide your email address? Jim Ryan is asking.
Absolutely.
Okay, it is on there, wconlon@mednet.ucla.edu, if you look in the chat area.
Which other?
Okay. See you in a couple weeks.
All right.
Okay,
I may not be able to respond to emails this afternoon, so just a warning. I'm not ignoring you.
Thank you, Wendy.
Okay.
Thank you, this was wonderful.
Take care.
Thank you.
everybody.
Thank you.
Stay
Good to see everyone. Carol.